Top Med Talk. Hi, it's Monty Mythen here, Editor-in-Chief of Top Med Talk. I'm here at a Peroperative Quality Initiative at the Washington Duke Inn in Durham in North Carolina, and you've been doing extensive recording with the team here about fluid management. But by chance, we just caught up with some friends that we've interviewed before on Top Med Talk. There was an interview that we recorded earlier in the year about cesarean sections and enhanced recovery for patients undergoing cesarean sections. Now, just to remind people, cesarean sections are one of the biggest bed users in our hospital systems. So I can speak on behalf of the United Kingdom, and patients undergoing cesarean sections, and remember, everything goes well, you end up with 2 patients, are the biggest bed users in the United Kingdom, and that's all great news. But lengths of stays are possibly longer than they should be. And in an interview recorded early this year by Desiree Chappell, that I'll lead anchor for Top Med Talk, we heard about some exciting developments with regards to enhanced recovery for patients having cesarean section. Desiree, over to you.
Yeah, we were able to catch up with some friends. Dr. Attila Kett, he is from St. Peter's in New Jersey. And Attila, we were able to sit down with you at the EBPOM meeting, actually, and talk about enhanced recovery for C-section patients. And you were telling us about really the incidence of C-section here in the U.S., so I want you to kind of revisit that. And then really what the benefits of enhanced recovery are for our for C-section patients. And then we have another special guest with us that you brought down here to Durham. And if you can introduce Liz and maybe you can tell us about what your experience with enhanced recovery is, Liz.
Thank you, Desiree. Thank you very much. It's great to catch up with you guys. Enhanced recovery after C-sections, it's a new topic in the United States, but in the UK, interestingly, it's actually called next day discharge. It is very popular. In the UK now, it's part of the National Health Service standard of care, and many hospitals where we know women go home as soon as even next day after cesarean sections. In the United States, we are unfortunately far behind. Our patients, while frequently they go home after hysterectomies, much older, much sicker, after C-sections, the standard is standing 4 days in the hospital after this operation. In St. Peter's, we introduced the first enhanced recovery program, and over the last 2 years, we really empowered our patient population, and now really introduced the culture change in the hospital. So our patients go home typically on the second day after the operation. And on top of that, they go home very frequently with no narcotics because we use a really effective non-narcotic pain management technique during their hospital stay. I am here with Dr. Elizabeth Shiro. Dr. Shiro and myself developed this program in St. Peter's together, and I believe that is really the essence to develop a successful program, to have an interdisciplinary approach. Dr. Shiro is the Vice President of Medical Affairs for Axia Women's Health, which is the largest OBGYN group in the country.
Thanks, Attila. Thanks for having me down, as I thought I was going to be following around a bunch of anesthesiologists talking about something new and different when everybody's been doing this all elsewhere. But our patients are doing fantastic. We started this back in 2016. Our patients are going home on day 2, but they're also quite happy and satisfied and engaged with the program. We educate them starting at 36 weeks throughout their perioperative period. They also are able to breastfeed earlier. They're ambulating earlier. They're able to communicate with us about the program and how different it is from their prior experiences, and have had great success with the program and getting patients home on day 2.
So many of us have been involved in the American Society of Enhanced Recovery or Enhanced Recovery educational efforts around the world. But I think this is one of the first times that we're going to be having educational programs that relate specifically to this area. So the meeting today that we sort of bundled in on was between you, our guests here, and Professor Sol Aronson from Duke University Medical Center, talking about having a specific session at the second EBPOM USA meeting, the Perioperative Practicum, coming up in Chicago in September of this year. So we bundled in at the end of that meeting. What was the conclusion?
So this is particularly exciting for me. We agreed that in September, we'll have a full afternoon, 4 hours devoted to this topic. And our goal is to include thought leaders from multiple disciplines, obstetrics, anesthesia, nursing. And also we will keep it very practical. So we will answer questions. What are the roadblocks, the potential difficulties with the program? What's different here than in the UK? And since, as I mentioned before, this program is many, many years ahead of us in the UK, we will have thought leaders here from the UK to tell us about their experience.
That's great, Attila. Liz, are there any other ideas coming from the obstetrics that will benefit from the meeting?
Yeah, we can talk about getting into the weeds with how do you change and start a new program, and how do you really get the culture to shift, and what the goals and aims, but also just how you roll up your sleeves and get something done. We've also invited Blue Cross Blue Shield thought leader Lily Brillstein, who is about value-based care and episodes of care in obstetrics, which will really talk about how bundled payments are, be able to think about that and help people look at that from in a national perspective.
Part of the mission with EBPOM and part of what we talk about repeatedly with enhanced recoveries, it's multidisciplinary. So it's just going to be docs talking to docs, or are we going to get the real workers involved?
We're definitely going to get the real workers involved. And in our program, from the get-go, when we started, we realized this is a big change. And to actually operationalize a big change, you need to use a formal change management program. We use the Cotter program, but even actually a more updated form of the Cotter program. So in our system, we developed like kind of a second network of change agents, which are typically frontline workers, nurses, breastfeeding education specialists, and multiple others who work on the hospital floor, in the labor and delivery unit. And we certainly will bring many, many of these people to the meeting, so they will be answer the very practical questions what may come up. How do you do this? How do you do this in this country?
The only thing I would add to that, Attila, is we started it. We've implemented it in my particular care center. We've actually implemented it in other care centers within Axia. So we're really starting to roll it out. We can give workflows. We can give the down and dirty of what you need to do, but the network that you need to develop to make it happen.
So one recurring question about enhanced recovery is whether it's good for the patient or it's good for the hospital. So I can understand why hospitals would want to get patients out quickly. Okay. Now, some mums who've had babies have turned around and say, whoa, hang on a second. You're telling me I could have 4 days in hospital that looks a little bit possibly like a hotel, and somebody helping me look after my new baby? Maybe, Desiree, you've got some views on that. You've done a bit of it.
Yeah, the thought of having someone else kind of take care of my crying baby at 2 a.m. is a nice thought. So the patients that you're taking care of, are they wanting to stay? Are they wanting to go home? How are they feeling?
You're absolutely right. The mom of 4 certainly would like to stay a little bit longer, but she wants to mobilize sooner. She wants to breastfeed better. She wants to be able to get up and take care of her other kids if she can. And honestly, that hospital bed is not that comfortable. Absolutely. Patients are engaged at 36 weeks and really understand why this is a better recovery. And if they understand that I'm not there to kick them out, they're actually engaging in the process and understand the flow of the patient, what exactly criteria they need to meet, and are empowered to be able to get out of the hospital sooner. But the success rate we've had is really been driven by the patients enjoying the process, comparing it to their last delivery, and the information they're given and feel that they're a partner in the whole process is amazing.
Attila, maybe you can speak to this. One of the reasons why I wanted to stay in the hospital was pain control. I really struggled with that personally, and I know a lot of moms moms that do, especially after C-section. So how is the Enhanced Recovery Program kind of addressing that, maybe specifically?
Yes, so it changed completely since we started this program. It used to be the traditional approach, what many institutions still using in this around here, using medications only as per needed, and typically mixing narcotics with non-narcotic pain medications. Percocet is a good example, what used to be the standards at our institution. Now we have a staggered schedule of non-steroidals with Tylenol, starting with IV formulations, going to PO formulations from day 2. And most recently, we supplement these medications with long-acting local anesthetics, which we are trying to determine what's the ideal route to administer this, whether a tab block or multi-layer surgical infiltration works better. In any way, our experience that as our first step, just switching to the staggered doses of non-narcotics, we halved our narcotic use from 60 morphine milliequivalent to 30, and now adding the long-acting local anesthetics, we're down to 10, 11 morphine milliequivalent. So what it means, about 50% of our patients or more are not needing any narcotic pain medications in the hospital. And what many publications show from before, in-hospital narcotic use very well corresponds to home narcotic use. So as a result, we able to apply shared decision-making with the patients, and we can present to the patient that how many pills are you actually comfortable going home, what your likely need will be, are you okay with that? Now, we also extensively use technology in our program. We have a cell phone application which helps us to follow up on these patients once they go home. So we know their pain scores and we know their narcotic use at home if there is any. And that helps us also to alert us for potential problems if the patient actually, either way, experiencing more pain than was expected. We had that problem before. Usually this is a red flag. It was a brewing infection, was actually treated well, and the patient avoided a hospital admission by that. Or more simple cases, just they need a refill, they need more medications, but at least we know about that.
We discussed quite frequently on Top Med Talk the issue of addiction that we believe has started as a result of meds that we have handed out to patients. Does the same issue exist with regards to mums having babies, including babies under cesarean section?
I know I personally went home with 60 Norcos.
So, interesting topic of discussion. When you sit with a bunch of obstetricians, they want to make sure that their patient is comfortable. It's the fifth vital sign. We've been drilled in that we really need to be attentive to this. And now we have a crisis on our hands of addiction in this country. And 1.3 million C-sections are done in the United States a year. And if I'm writing, and if the C-section rate is somewhere around 30%, and our data is going up, the 1.3 million sections are all getting some kind of narcotic prescription. We've reduced that down to 50%, and I would even argue even higher. We've reduced the narcotic use. But more importantly is that the patient goes home with no prescription, so that they don't have a filled tablet sitting on their medicine chest, that when someone has a back pain or slipped and hurt themselves, that they're now getting addicted, because 4 out of 5 opioid users get addicted by a family or a friend's prescription in this country. So I'm no longer contributing to that because I'm not adding to that pills that are circulating. Within our program, one of the interesting things we've done recently is patients don't even understand how to dispose of their extra medications. So we've asked patients to bring in their scripts, whether they're unfilled or whether they're still, the whole tablets are still in their, whatever's left over in their prescription, so that we can help them dispose of it, so that they won't have family members that are getting addicted or have the idea that, that's sitting on their shelf for potential use.
So Sol Aronson's just joined us, the principal leading that meeting in Chicago. So Sol, if you don't mind, we've just said that it's going to be exciting that we're going to be talking about cesarean section enhanced recovery, I think for one of the first times at a significant meeting in the USA. Why do you think this is important?
Well, I think as we continue to expand horizontally and vertically the breadth and depth of all things perioperative, this is just one special, important, additional, member and topic and sort of space to add to this continuum of the evolving science of perioperative medicine. We're extremely excited to be the sort of the home base of adding this important discussion to what I think is the global conversation of perioperative medicine as it continues to evolve. So welcome to the family.
All right. Well, great discussion. Thank you guys so much for joining us down here at Duke this weekend to talk about all good things surrounding enhanced recovery for obstetrics. We look forward to seeing you guys in Chicago this fall, September 28th through the 30th. We're going to have a whole afternoon dedicated to enhanced recovery for obstetrics. Some great speakers there. So please join us for that. And please be sure to follow us on all your favorite social media, Twitter, Facebook, LinkedIn, Instagram, and join us on your favorite podcatcher to catch up on all your favorite content from Top Med Talk.
Top Med Talk.